to give a presentation on a very challenging topic because, as you all know, AMH is a marker which has been introduced a few years ago in the field of human reproduction. But I think it's correct to say that we need to be critical. We need to be self-critical on the role of AMH in ART. So I think it's an excellent topic which has been selected by yourself. Now, if you take a look at the ovarian reserve, we know that the ovarian reserve of a woman, it's actually a very inefficient system. If you take a look of a 20 weeks embryo, female embryo, that embryo has around 7 to 8 million eggs. The moment the girl is born, it contains around 1 million. So you could say 1 million is a perfect number. I don't want to have 1 million children. The problem is when you are born, you're not ovulating. So your first ovulation occurs at the age of, let's say, 12, 13, 14 years. And at that time, you go from 1 million to 300,000. And during your lifespan, from these 300 or 400,000 eggs that you're having, you will ovulate around 400 to 500. Now, the problem is many of these 400 to 500 will also be genetically abnormal. So as you can see, it's a very inefficient system, but still it seems to work because it's 7 billion of us in the world and the number is steadily increasing. So if you would have a look at the histology of a 10-year-old, 20-year-old, and 30-year-old, you see there are significant differences with the prevalence of the eggs which are present in the ovarian tissue. Now, one of the ways we are looking at women to understand the ovarian reserve is to stratify the patients according to the age categories. The problem is not every age category has the same ovarian reserve. You could have a 25-year-old who is a normal responder. She could be a high responder, but she could be also a poor responder. So age is not the only variable which would be a reflection for us for the ovarian reserve. Of course, it is one of the factors we need to put in consideration, but it's not the only factor because at any given age, you can have, at any given fertile age, you can have a high responder, normal responder, or a poor responder. Now, if we go for ART, if we go for ovarian stimulation, if you have a poor responder, you want to harvest all the eggs you have. If you are a normal responder, you want to have 70 to 80% of the follicles you are seeing. And if you are a high responder, the last thing you want is to recruit all those follicles. So we need to have a basic understanding on the ovarian reserve in order to increase our efficacy, the way we are stimulating women. Another reason why ovarian reserve testing is important for us is, as you can see from this publication, the blue bar, the live birth is not only linked to age, but it's also linked to the ovarian reserve. So ovarian reserve is for us important because we can also predict the live birth of women. Now, if you look into folliculogenesis, if you would make a cut into the ovary and you would have a look at the tissue, you will see that there are different stages of folliculogenesis. So you have your primordial follicles, then you have your primary follicles, antral follicles, and then pre-ovulatory, ovulatory corpus luteum, and so on. But this is an important slide. I think this is where we understand the basic physiology of an ovary. So in fact, it's interesting to know that from the time that you have an egg until it's going to be ovulating, it is taking in total more than 220, 230 days. So it's a very lengthy process. And what is even more intriguing during this process is that only during the last, let's say, 3 weeks of this process, these follicles are responsive to gonadotropins. It means your FSH or LH, it's only the last fraction of time where these follicles are responsive to LH or FSH. Now, what is the role of AMH, the hormone that we want to talk about today, is that AMH is preventing, it's inhibiting the primordial follicles to be recruited to go towards primary and secondary follicles in order to become responsive to FSH and LH. So in fact, one of the roles of AMH, which is being produced by primary and secondary follicles, as you can see here, it is a negative feedback in preventing primordial follicles to be recruited and to become responsive to gonadotropins. Another slide, as you can see, the same pattern. AMH is having a negative feedback in order to prevent primordial follicles. And by the way, I think this is something which we need to think about in future when we are dealing with poor responders. Maybe that we can think about a kind of anti-AMH in order to recruit more primordial follicles for the so-called poor responders. So as mentioned previously, the maximum expression of AMH is by pre-antral and small antral follicles. But that's not all, because even a small antral follicle up to a size of maybe 6 to maybe 7 millimeters still will produce AMH. So it's not that the antral follicles that you can visualize on your scan, they do not produce any AMH, although they produce until a size of 6 to 7 millimeters. And it's a good indicator of the size of the ovarian antral follicle. And this is also why you will see later that there are also intercycle variations between the AMH, because if you have follicles of 5 or 6 millimeters producing AMH, and you have the intercycle variation of the antral follicle count as published previously by Griesinger, we know that also the AMH might vary significantly. Now, AMH is for us important because we can anticipate the response of the patients, we can diagnose possibly a PCO, we can diagnose a hypo or a patient with ovarian failure. But AMH is not the only value we are relying on. Of course, we have also our ultrasound techniques with a high resolution, where this has improved significantly over the past few years. So you can really identify the number of follicles. And today with a 3D scan, obviously we have a detailed view of also antral follicle count. So if you put the antral follicle count and AMH, we see that both of them are predicting the ovarian reserve. They are reflecting the ovarian reserve if you have a high response or you have a low response. So they have high specificity, as you can see in this graph. So if you put the age, if you put the antral follicle count, if you put the AMH, and if you put also the FSH, I will come back to that point later, then you have really a good predictive value on the ovarian response of a patient. Now, it has also been proposed, especially from the Dutch, that AMH can also predict the age of menopause. So basically, based on the value that you have, you can make a calculation when the patient will reach the age of menopause, which is interesting for some women to know. But it's important for us that we don't focus only on one value, because as you have seen, it's very dynamic and there might be intercycle variation or even intracycle variation. So you have seen that AMH is produced by these small antral follicles, and it has a negative feedback on the primordial follicles. But at some point, when these follicles are becoming responsive to FSH and LH and they grow, they stop producing AMH. So maybe we need to have a more objective assessment of the so-called functional ovarian reserve, that we look to other variables in order to anticipate and make a prognosis of the patient's response and possible outcome. So if you are going towards a personalized prediction of the ovary, there are various factors that we have to put in consideration, because at the end, we want to individualize the treatment as much as possible. We want to have a correct counseling. We want to predict the outcome. We want to reduce the collateral damage. We want to reduce the possible problems that we would cause by stimulating that patient in order to have the optimal outcome for that particular patient. Now you have seen that age, of course, has an impact on the quality and quantity of the oocytes. Now why is it the quality? Because it seems to have an impact on the genetic information of the oocytes. This is a beautiful paper published in FNS by Jason Fansek from Richard Scott's group in New Jersey. And as you can see, and this is not novel to us today, age has an impact also on the genetic information of the oocytes. Even if you do a genetic assessment, if you check the chromosomes of an embryo and you make sure that you are having a chromosomally normal embryo, if you look to different age categories, if you transfer an euploid blastocyst at the age of 35 or 42, as you can see, there is a significant decline in clinical pregnancy, implantation, and live birth. So it's not that it's all only in the genes. There is more than that. There is more behind that. Age also plays a role. Now, based on this concept that AMH is not the only thing we need to focus, Norbert Gleicher published this paper a few years ago looking to actually various factors in order to have a better prognosis for the patients, to tell them what is a prognosis. And I think it's a beautiful idea not only to look to AMH or age, but also to have FSH of one of the predictors. I think many of us, we are completely neglecting the FSH. We say now we are fancy, we have AMH, and AMH is very stable, we know exactly what to do with it. But I think FSH is also a hormone which should not be neglected. And of course, FSH should always be measured with estradiol because, as you know, FSH and estradiol are controlling each other. But if you have on day 2 or 3 of the cycle low estradiol and you have your FSH value, based on the FSH value that you see, the higher your FSH, the lower seems to be your outcome because also the quality of the oocyte is decreasing. So you can see pregnancy and live birth decline significantly with every step as your FSH is increasing. So going back to AMH, so you have the antral follicle count, you have the AMH. Of course, AFC today is very easy to perform. You do your scan, you measure your follicles. It's not invasive. Immediately you can tell to the patients what is the status of the follicles, are they fully synchronized, and you can immediately know how to go ahead. And to me, it's important because what you see is what you get. It's seeing is believing. With AMH, obviously, it's well characterized. We know that you can rely on it, but can you rely on it 100%? I will come back to the point. Most probably not, because there are also significant variations. Up to 2-3 years ago, when you were speaking about AMH, everyone was saying, yes, it's because of the assay. It's not fully automated. Maybe because of the assay we are using, we have significant variations. It was true. There were significant variations because the assays were not measuring it correctly. But today, we know it's not only the technical variation that we are dealing with. Today, we know that it's also the biological variation we are dealing with. Why is there a biological variation? So this is a paper we published about 1.5-2 years ago, where we described that actually if you use the fully automated assay, you have significant variation within the cycle and between the cycles. So as you can see, you have here more than 20% intracycle variation within the cycle. Laura Melado is the first author of that paper. But also, if you take a look at between the cycles, up to 30% almost intercycle variation, meaning you have 20% variation within the cycle and up to 30% variation between the cycles. So you would come up to 50% variation. So is this really reliable? Big question mark. Yes, of course, it seems to be reliable, but I think we should be cautious of relying everything we know on the AMH value itself. So we have seen there are significant variations, and one point that we started to look in very recently is also the AMH isoforms. And here we have very limited knowledge. So I think it would also be worth to have a look better on the AMH isoforms, but unfortunately we don't have enough publications on this topic. We have tried to look into that, but it's very difficult to do studies, but I'm sure in the near future, many pharmaceutical companies will come up with new studies on also AMH isoforms. Now, what are the cutoff levels? Of course, it depends if you're looking in nanogram per ml or if you're using a picomole or other units. We use, for example, nanogram per ml. So basically, you can go from a normal value being 2, 3 to 3.5 to 4 where you would expect a good response, a good ovarian response. And of course, if you go above 4 to 4.5, then you would expect a high response. And according to the Bologna criteria, if you go below than 1.2, 1.3, then you would be in the lower part. And of course, there is also a correlation between the antral follicle count and the AMH. So if you have a patient with an antral follicle count of 15 and your AMH comes out at 0.5, then a lamp should go on. Maybe there is some contradiction. So I think this is also an important point. What is the best time? There is no best time, but currently we just have to inform patients that AMH is not a fixed number, that there could be significant variations within the cycle and between the cycles. Now, most probably you know this paper which was published by Nikos Polisos 2 years ago. We want to have a good number of eggs. At some point we have presented that maybe the more eggs we have, the higher is the chance of having a live birth. This is true. But of course, this is also based on the way we stimulate and the age of the patient. We know that AMH is also a factor which is impacting not only the quality of the egg, it might impact the survival rate of the oocyte. Again, we published that with Laura Melado recently, that I will come back to that. AMH could also be a qualitative marker for the oocyte survival rate if you want to accumulate oocytes, for example. Embryo quality, it could be a miscarriage predictor independent of age. And of course, Antonio Lamarca and Ana Hernandez from our group published a paper also recently looking to the euploidy status based on AMH. So this is a paper where Laura presented at ESHRE, and the paper I think was published last year, where we looked to AMH and oocyte survival rate, and it came out if your AMH is less than 1.09 nanogram per ml, your survival rate of the oocyte will go down. It means you would be possibly damaging these oocytes, because very often for poor responders, what we used to do is pooling the oocytes. You want to increase the number of oocytes to do IVF or ICSI after that. And here we have shown maybe this is not a very good idea, because if you are accumulating, banking these oocytes with the extreme poor responder, you might reduce your efficiency because your survival rate might drop. Also with the embryo, it seemed to have an impact. On the other side, what is the impact of AMH on the euploidy rate? And I think this is very important to have a look at. This is a paper which was published by Renato Falcian's group from Paris, where they clearly demonstrated that independent of age, the miscarriage rate increases significantly. It means AMH is not only a quantitative marker, it seems also to be also a qualitative marker. Qualitative, you have seen from freezing of the oocyte, but here you see it could also be linked to the chromosomal information of the embryos. With other words, if you have a 25-year-old patient with a reduced AMH and you have a 40-year-old with a good AMH, maybe the 40-year-old might have a better chance of success than a 25-year-old with a very low ovarian reserve. And in the same pattern, Antonio Lamarca's group from Italy published this paper, and these two papers were published more or less in the same time frame in fertility and sterility, where they described the same thing, that actually AMH, independent of age, is also linked directly with the euploidy status of the embryos. We published the same with Ana Hernandez, the same data. We looked into AMH and euploidy rate, and it seemed that yes, AMH is also having a direct impact on the euploidy rate of the embryos. So putting together, it seems that AMH is not only a quantitative marker, of course it is, because it's linked to the number of COCs, metaphase 2, 2PN, number of blastocysts, but it's also a qualitative marker because you have an increased rate of euploid embryos. So I think if we put back together everything which I just have presented, AMH is a very good marker. It reflects the primordial follicles. AFC is also a good marker of ovarian reserve. It is age-specific, yes. With age, globally, you go down, but of course, as you have seen, there are significant variations. It can be done at any given time. Also, the antral follicle assessment can be done at any given time. Of course, if you do it mid-luteal, you might have your dominant follicle where the patient is ovulating, but still you can count your follicles. It predicts the response of the patient. But at the end, we should not neglect the significant intra and intercycle variation. And I always say, seeing is believing. What you see is what you get. So I would not put all my knowledge on one factor being AMH. I think we need to have more variables in order to have a very objective assessment of that patient, meaning AMH, AFC, FSH is also very important, as you have seen from publication by Norbert Gleicher. And of course, age. If you put these variables together, I think you have a more objective assessment of the patient. Thank you very much.